That's the way. How do you find the success rate if you actually like do the physical therapy? My problem is I'll go to my physical therapist and I just won't do the do the exercises. And then is there surgery? I mean, I don't want surgery, but like I heard.
So there's a certain amount. Like you can have damage to the fascial tissues and integrity in your pelvic floor, and no amount of exercise or recruitment is going to fix that. If you need that repair, then you need that repair. What we often will see is that those women also have more strategies, and so if you look at the outcome measures of what's happening post-surgery, they'll be fine for a while, and then a certain percentage of them will not have a good outcome. So I do think it's important that even if you're going to have surgery, first of all, that you learn to recruit these things and make sure you want to avoid surgery if you can, but then to get a better outcome post-surgery. The same, and surgery has its own, now we're starting to mess with integrity of different fascias, right? And you can get scar tissue and different things that can affect that. So I find depends on every individual person. I used to be, I would be, people would come in and go, well, I didn't do my exercises. And they go, you're probably going to be mad at me. I don't get mad, but what I find, if I really can find the right exercise that's really relevant, and they can see the value in it, that I have a much higher percentage rate of compliance. So those exercises, they need to make sense to you, and they need to be the right ones, I think. And that can be tough, because some people, like I say, they're coming in and they want exercise, and I'm like, okay, here's how I want you to hold your pelvis, rock it under, arch it out, no, don't hold your breath, line up real tall, imagine, and we might have to start way back down. This is a deep system, it's underneath, it's not, if I could just give you these and send you on your way, everybody, my job would be easy, right? But that's when I think you get into some failure. I can't just put you in a plank and say, look how strong your core is. I put plenty of people in a plank, and first of all, they can't get into good alignment, they breath hold, they push out, and they're not firing. So a lot of factors can, I don't know, see I started talking again. You gotta be careful.
Yeah. Is this effect cumulative with more pregnancies?
Yeah, I do think you are more common to see that picture I had of that woman, and actually a woman I had the other day that had a really large one. It will be with multiple pregnancies or multiple births at one pregnancy. The bigger you get, the more stretch you're going to have. Some women carry way out in front, and I see these women sometimes, and I think, gosh, I can hold the baby, like, the baby's not in your cavity at all, it's way out here. Those women often have a little bit of harder time, and I don't know what their transverses look like before. I also don't know what is their general connective tissue state, because we all have different levels of how firm our tissue is, and how quickly we deform and how quickly we come back. So, but yeah, it makes a difference.
Knowing that it's different for everyone, and
sure.
the rectus muscles coming back, so I'm sure you can't say, oh, in general, I recommend everyone kind of not return to their core exercises for the first 6 weeks or something. I'm just trying to get an idea of, would you consider it not a good idea to return immediately, tell everybody blanket statement like,
No, I don't think you could do that. I really like to encourage women to get active. What I tell, if I see people, I see a lot of women during their pregnancy talk about what to do postpartum. Walking is often safe. I don't always get the nice recruitment that I want, but getting up and getting moving I think is really important. And we talk about what's happening here. Are you really pushing out? Are you getting that doming out? Does it make your back ache? Those kinds of things. I think if it's doing that, if you're getting symptoms, then I think you have to do something a little bit different. But I'm always trying to figure out, like, if you can't do that, what can you do to get you there and keep you moving? Because I think it's important to move. Yeah. And there's no blanket statement, because some people did abdominal crunches, which I'll never give, and they did them with really low pressures and do them very nicely. I never give that lift both feet up and do that, but I have people come in sometimes and I'm like, okay, show me, and they do it, and I'm like, yeah, you can do it. Like, I don't want to give it to you, but I really don't have a reason. That's like my own bias. They do it just fine. So it's how you do it.
What about, what are your thoughts on like a belly band or a girdle?
I love supports. I gave one to my woman just yesterday when I told her she was like over 5. She did really deep stuff. But I have her doing some exercises right away, and I found that she had back pain. She didn't even realize that her back was aching that much until she put it on. So I might do it to increase your function, get you moving, decrease your symptoms, so I can get you moving and really build on that. I'm not afraid of braces. I think we brace ankles, we brace knees. I don't know, just make your back move. If we're using it to get somewhere, I use them. I don't standard everybody, you know, I had a baby, should I be in a van? No, I don't do that.
I was gonna say, on top of that, like I've heard a bunch of different, like, there's a few programs that use splints. I think that's what you're talking about. Is a splint the same with a girl?
A lumbar sacral support, or a SI belt, or a belly binder, like that is what you mean?
I don't know if it's the same, like I've seen them, yeah, they're called
It wraps
splints,
around, it's
yeah,
got
wraps
Velcro,
over.
and you tighten it up.
Yeah.
Yeah, men use them for lifting, like heavy jobs and heavy lifting, and so yeah, I think that's what she's talking
I
about.
read the people that are in support of that say like sometimes that's the only way to build the connective tissue back, like give it, because you can, I think my problem is like I can do these exercises,
Right.
and there's just so much of the day that they're separated.
Right. So we can use it as a protective thing, but it's not the bringing together itself that's helping your connective tissue. I can't just take the two connective tissue pieces and put them together and get healing. But what it's doing is trying to minimize that constant pulling apart with the obliques or with the hard back extensors. So that's that camp, right? What I find is I'm in all the camps depending on the patient, and sometimes I put people in them, and sometimes I say, you know, I don't think that's a good idea for you, and some women don't want to be in them. You want to belt them for a reason. They're like, no, I don't really want to wear that at work. People always ask me about it. You know, there are lots of reasons why they might not, or they might have an inherent idea that it will make them weaker. So some people will tell you the gap is more important than the depth, and some people will tell you that the depth is more important than the gap, and I'm here to tell you I think it's probably both true. It just depends. Yeah. I think more depth though, I would say. Yeah.
So there's like belly bands you can wear during pregnancy that are kind of more stretchy, but kind of, you know, kind of like a compression to kind of keep everything together. Do you think that that's kind of giving like a facade of like allowing you to maybe injure yourself?
So I think you have to use it as a part of a program, and I don't think, it's the same way if you had an ankle sprain, I wouldn't just go, here's a brace, go play basketball really hard, and still have a problem. I would give it to you and then work on your range of motion and work on your strength. So the same thing with the belly band. It can be a really nice support for those women who carry really far out or who have multiples. Actually, I have one of the midwives I work with, she likes to use them to help encourage the later in pregnancy, to help encourage the baby to be able to drop down into the canal better and start to get pressure on the cervix. So we use them, but I think you have to use it. I think the women during pregnancy should be training the system to stay awake and to stay supported and to watch these changes.
So I'm only 17 weeks, I'm not like huge, but like I just feel like when I'm running, like everything is jumping, like and I feel like I'm gonna pee my pants. So like having like a little bit of like support.
I think that's a good point to make, because here's the thing, a lot of women continue to run during pregnancy, and I think if you do, that's fine, but I think when your body's giving you feedback that maybe it's not the right thing for you, all of our organs are held up by suspensory ligaments in here, and those ligaments get stretched out, they don't go back. I have one set of ligaments that hold up that uterus, and every week that baby's getting bigger and that uterus is getting heavier, you know, just even with placental growth. And I'm taking that and I'm doing this to it. And so I can really challenge that suspensory ligaments. And so if you're having symptoms of I'm feeling vulnerable to incontinence, something's not supporting you well, and your body is telling you a little bit of something, right? Yeah. And I think if we paid closer attention to sometimes these signs and symptoms, we could avoid a lot of different problems. That's like a whole other lecture talk. So sometimes I will support these women to get them to run. Sometimes I will try to encourage different activity if that's not the right thing at the right time for them. Because just because somebody runs during pregnancy doesn't mean everybody should run during pregnancy, and the same holds true if you're not pregnant, right?
What about, so I haven't had my baby yet, but but I'm wondering, for me, do I want to wait if I have a diastasis? What is a safe point at which to start more rigorous exercise, or to try it? Would you want to wait till you've been evaluated to make sure you're less than 2 fingers? Do you want to make sure
well, so probably your caregiver will look at that. My friend, I get women that come in and they're like, oh, my doctor told me I have huge diastasis recti, and I look at them, I'm like, everything comes back together really nicely when we move. You're fine. right? So what we really want to work on right away, immediately postpartum, is you could start to get pelvic floor activity going, get increased circulation. It's hard to find, start to wake it up, get it going again.
But you don't want to do a crunch or something.
I already said I don't generally give out crunches, right? But
Yeah.
it's all about what can you control, and we want to start working on that control right away. So if you could do a little bit of a pelvic floor activity, and you go to lift your leg, you will say you go to lift your leg and your belly pops out, then that's probably not an exercise I'm going to give you, but I might give you, let's learn how to control that, get a little bit of support here, and then go to lift your leg and hold that, and that might be a great place to start. Rigorous is probably different than, say, everybody else in here. I was going to call you out. I guess I did, sorry. Yeah. So we all have different rigorous, yeah?
So do we need to get away from that language of we've had kids, like we are going to be incontinent? Like we're just, generationally, you'll be like, oh, well, you know, like when I can't jump on a trampoline, like I've had
Well, so at least
kids.
women are talking about it now. I
Right,
mean,
like-
like my mom, you know, you can't say urinary for heaven's
Yeah.
sakes.
So
Let
be a
alone
little bit more
incontinence.
upfront.
But, you know, just recently, I think in the past, I don't know, is it 5 years now, the whole CrossFit thing happened, and women were celebrating their incontinence. When you're not working out hard enough, if you're not wetting your pants.
Crazy in the other direction. I don't know.
Well, I think that that's a problem, and
Yeah.
I mean, I'm not the only one to say it. The experts out there, because there was like a huge big uproar. People were writing letters to the editor, and they were having panel discussions, and if that is happening, that is a problem, right? It's not just a problem of incontinence. Incontinence is the symptom. Somehow you're not controlling things well, and that might just be the first part. You could end up with fecal incontinence. Nobody's saying, hey, great, you know, look how hard I worked out for that. But it's similar. And there's, you know, compressive forces in the back and the hip and all kinds of things that can happen. But yeah, I think we should be saying it's a problem, and it's a problem that can be addressed. If that's
Not
what
just
you're asking.
accepting it.
Not just
as
accepting it. Oh, you
as-
know, I get that a lot. Oh, you know, not any more than the usual amount. Well,
Right.
what is the usual amount, you know? Boys likes it, that we all do, you know? They're making all kinds of fancy pads and gadgets, and you can now get really lacy feminine underwear that has room for a pad in it that you don't need. So, yeah, that's one solution.
Yeah, I'm just trying to wrap my head around where like your endpoint is. Do the muscles actually physically come back together where you're measuring an improvement, or is it more symptom related?
Yeah, I look at function. I like function. Some women will come back together, and some women will be separated when they go to move, they come back together. But if you have that nice connection underneath, and that when you go to move, everything's working fine, then I don't care. I'm less worried about if it comes back together or not. But yeah, some women will and some women won't. And I had this really cool picture that I put in here about this super fit man who obviously had never had a baby, and he had no body fat, and you could see every one of his little muscles, and you could see that he had diastasis recti. And he's certainly high functioning, right? He's just overdeveloped the obliques and pulled that apart. So I don't think I'm in the camp of depth and function versus distance.
So, full disclosure, I have an umbilical hernia related to mine, and I didn't know what it was when I first started feeling it. It happened, I think I noticed like a year or two after my second daughter. And then of course I can see it in other people now when they're pregnant. It looks like you have two belly buttons, But I guess, can you talk a little bit about that and like how that's related to this issue, and how often do you see that?
So what happens when I get a thinning of that tissue and a separation, then the contents of your abdomen can poke through that. That we have to watch for, because that could be a pretty serious thing if part of your intestines come through and gets cut off. So that could be part and parcel. You can have a diastasis without a hernia, but that probably needs to at least be cleared by a doctor to make sure that we're not, and we definitely want to make sure when we're doing activities and exercises that you're not increasing pressure or pushing out on that, and we support that help. I'm not sure I quite answered your question.
Do you see it very often?
I don't see a lot of those. I think maybe they get screened out a little bit, because I don't specifically treat hernias. I do think that people who have hernia surgery probably could get helped by learning how to control their pressure, so I think that that's part of it. Yeah, men break down more here in front, somewhere hernias along here, women have more problem down here, part of that has to do with anatomy. But it's the same pressure system problem.
When you talk about the belly coming out, you're talking about building a rig when you go to do that.
So I see two things. I see the doming up through the diastasis. So yeah, everything sort of domes up and out because it's not coming together. But I see people who stabilize, who don't have a diastasis recti, where they push their belly out like this and they use their breath to stabilize, which is not the same thing as getting the improvement of the deep system. So I look at both those things, and I give my patients instruction on neither, unless we're really doing something super heavy that they need that extra jerk sort of work. Yeah, we shouldn't be using breath holding patterns to get up out of the chair, to walk across the room. Those should be a much higher level tax to our system, but sometimes we use these just to get basic activity just throughout our day, and it's not the most efficient or optimal way to do it.
So I have like a 7-week-old, and I do that a lot, like getting out of chairs. I have to like, okay, here we go. Is it just because I'm having a baby, or is it maybe part of all of that too?
I think that there's a weakness issue with that,
Okay.
right? Yeah, you know, things are.
I contract. I'm ready to go.
Yeah, and
Okay.
I teach that to people. I might need you to give yourself some support while you build strength to do that.
Okay.
Yeah, we teach that. Keegan, did you have a question?
Yeah, I was just wondering how common it is for insurance to cover postpartum PT work.
I haven't had any trouble because usually there's a diagnosis that we code, like back pain, pelvic girdle pain. Stress urinary incontinence is one of the things I code for as well. Weakness, we could treat weakness. So that's usually a common one I throw on everybody's because that's what I'm doing is building up their strength in that system. Haven't had, knock on wood, any trouble yet with the ICD-10 codes. I think that might change how we have to code stuff. But it's considered, painful intercourse apparently is not considered a good reason to get treatment, which I find a little bit bizarre. But insurance don't like to pay for that, so you have to look at what are the other things coming around with that. But incontinence, I haven't had any trouble with.
Do you get a referral from your OB to come see you?
You can get it. Some insurance companies require you to have a referral. Some don't. It can be from your OB. It can be from your general, nurse practitioner. It can be your general physician. I get them. Well, I get them from family docs too. Yeah. Colorectal stuff I get now too. Good. Thanks. I appreciate you guys coming. It was great to share this information.